Good evening, ladies and gentlemen. Anesthesiologist, I want to welcome you for today's CME. The topic is on VTE, thromboprophylaxis in adults. Our speaker today is from London. Is a perioperative medicine fellow from the Department of Anesthesia, and I'd like him to carry on. Welcome, Daktari. In our country, we call doctors Daktari. So welcome, Daktari.
Thank you so much, Leslie. So good evening, everyone. Thank you so much for having me. Let me just share my slides. Can you see my slides?
Yes, we can.
Perfect. So again, good evening, everyone. I'll be presenting an interesting topic that sparked my professional interest because deep venous thrombosis and pulmonary embolism are quite common conditions with potentially catastrophic consequences. I personally had a couple of cases of pulmonary embolism during my career and have also attended a cardiac arrest call of a patient on ward not so long ago, which later had confirmed massive pulmonary embolism, which luckily the patient survived the cardiac arrest, but unfortunately there were neurological consequences of that. Today we'll explore the broad topic of perioperative venous thromboembolism, thromboprophylaxis in adults. In this comprehensive presentation, we will address various aspects of this very broad topic with heavy emphasis on the latest clinical recommendations for your daily clinical practice. So without further ado, let's get started. We're going to briefly go through the epidemiology of VTE, along with the most important question in hemostasis and thrombosis. And does the balance of procoagulant factors outweigh the anticoagulant factors, and does necessitates measures to reduce prothrombotic state? Next, we're going to explore the risk factors for VTE and various ways of doing the VTE risk assessment, along with a couple of VTE risk reduction strategies. We're then going to have a quick look at the UCLH local guidelines, and then we're going to conclude with a comprehensive overview of the latest international guidelines from European Society of Anesthesiology and Intensive Care that were published in August 2024. So to put things into perspective, let's first review epidemiology and incidence of venous thromboembolism. So venous thromboembolism is basically an umbrella term for two conditions, and namely the first one being deep venous thrombosis, which is when a clot forms in the leg, and if that blood clot breaks loose and travels up to the lungs, it's called pulmonary embolism. So the available data shows that 1 in 4 people die from causes related to blood clots, and that VTE is among the top 3 cardiovascular killers globally. Also, VTE is #1 cause for preventable death in hospitals, and almost 2/3 or 60% of all venous thromboembolism cases occur during or following hospitalization. 1 in 8, or roughly 9% of the population, experience a VTE during their lifetime, and the incidence of VTE has not declined during the last decades. Quite the opposite. Rising prevalence of major VTE risk factors such as aging, obesity, cancer, and surgery have likely contributed to the persistent trends in the VTE rates, and the VTE is associated with 2 to 3-fold increased risk of work-related disability pension. Of all the known risk factors, obesity remains the strongest patient risk factor associated with lifestyle, and 10 to 30% of all VTEs can be attributed to being an overweight or being obese. There is intense ongoing translational research integrating population-based omics and also experimental studies that may reveal certain biomarkers and mechanisms of VTE, making it easier to predict, detect, and treat in the future. For now, we don't have much in our hands, but the research is promising in that era. WHO data revealed that there are almost 10 million hospital-associated VTEs every year, and that VTE is the leading cause of adverse events due to hospital admission in low and middle-income countries, and is also the biggest cause of lost DALYs or disability-adjusted life years as a result of hospital admission in low and middle-income countries. Lastly, VTE causes more hospital-associated adverse events than catheter-related sepsis, hospital-acquired pneumonia, and falls combined. According to Barco and co-authors and International Thrombosis Steering Committee data, VTE causes more than 40,000 deaths in Europe every year and an estimated 30,000 VTE-related deaths in the US each year. Also, they estimate that VTE is estimated to cause at least 3 million deaths a year worldwide. Interestingly, despite these figures, VTE is not mentioned in the global burden of disease, nor is it mentioned in the WHO website in either patient safety or non-communicable disease sections. Obviously, World Thrombosis Day and International Society on Thrombosis and Hemostasis are working on including this important healthcare metric alongside other currently established metrics of quality and safety in healthcare. The main age-old problem in perioperative VTE thromboprophylaxis is obviously the fine balance between bleeding and thrombosis. Different procedures entail different bleeding risks, and certain patients are more prone to bleeding than others, such as patients with hemophilia and von Willebrand disease, for example. On the other hand, for example, prosthetic valves patient risk factors for DVT/P in a patient with stroke present unique set of challenges in decision-making for VTE thromboprophylaxis. So Virchow's triad, or the triad of Virchow, describes the three broad categories of factors that are thought to contribute to thrombosis. Namely, they are stasis, vessel wall injury, and hypercoagulability. When these factors intersect, they significantly increase the risk of thrombosis. And we're going to look at them in more detail. So factors related to vascular wall injury include trauma or surgery, venipuncture, chemical irritation, heart valve disease or replacement, atherosclerosis, and indwelling vascular catheters. Factors related to blood or circulatory stasis are atrial fibrillation, left ventricular dysfunction, patient immobility or paralysis, venous insufficiency or varicose veins, and venous obstruction from tumor, obesity, or pregnancy. Lastly, factors affecting hypercoagulable state of blood are active cancer or malignancy, pregnancy and peripartum period, estrogen therapy, trauma or surgery of lower extremity, hip, abdomen, or pelvis, inflammatory bowel disease, sepsis, and thrombophilia, such as factor V Leiden. Clinically, risk factors can also be sorted in terms of acute and subacute triggers, as well as basal and acquired risk factors. In the acute triggers group, most common risk factors for VTE are surgery, fractures, and minor injuries, with hospitalization itself being an independent risk factor for VTE. Infection, COVID-19, and COVID-19 vaccination are also recognized acute triggers for VTE, and subacute triggers are inflammation of various etiologies and altered hormonal states, such as during oral contraceptive use, which we'll address later on during this presentation, hormone replacement therapy, pregnancy, and exogenous testosterone. Basal risk factors that predispose people to greater VTE risk are older age and sex, where women are at greater risk for VTE during their reproductive years and men at modestly greater risk at older age. Physical inactivity, poor quality diet, and ethnicity are also factors affecting VTE risk, but obesity is the strongest VTE risk factor, as mentioned previously. Cancer and cancer treatments, autoimmune disorders, and other clinical conditions such as heart failure, atrial fibrillation, and previous venous thromboembolism are also known acquired risk factors for VTE. So bearing risk factors in mind, one of the first steps in VTE thromboprophylaxis, as per our local, so University College London Hospitals Trust guidelines, is assessing the risk of thrombosis. Patients with certain hematological disorders, such as hemoglobinopathies and myeloproliferative disorders, are at variable thrombotic risk, and these patients may require extended duration thromboprophylaxis and should be discussed with coagulation or hematology specialists in our institution. That would be the coagulation registrar. And patients undergoing surgical procedure with a total anesthetic and surgical time of more than 90 minutes or 60 minutes for pelvis and lower limb surgeries are at an increased risk of VTE. The same is true for acute surgical admission with inflammatory or intra-abdominal conditions. And in the case of thoracic surgery, empyema is one of the most common or the most prominent inflammatory conditions increasing VTE risk in thoracic surgical patient population. As mentioned before, there are surgical risk factors and also patient risk factors, which are older age or age greater than 60 years, obesity defined as BMI over 30, dehydration, significant heart, metabolic, endocrine, or respiratory pathologies, acute infection and inflammatory conditions, active cancer or cancer treatment, hematological malignancy, varicose veins with phlebitis, or personal history of VTE. Additionally, as mentioned earlier, various thrombophilias and other thrombotic conditions, hormonal replacement therapy, or estrogen-containing contraception are also important patient risk factors. Lastly, pregnancy and postpartum period, as well as the continuous travel of more than 4 hours, approximately 4 weeks before or after surgery, are known to confer an increased VTE risk. And finally, there are known medications which are presented in the table in the right upper part of the screen, such as tamoxifen, corticosteroids, cisplatin, thalidomide, lenalidomide, which by various different mechanisms increase VTE risk. So once we assess the risk of thrombosis, we assess the risk of bleeding, which should be easier knowing the type of procedure, and this assessment should be done once every 24 hours or earlier if clinically indicated, to ensure that the risks and benefits of thromboprophylaxis are monitored and VTE prophylaxis is being used correctly. Besides the type of surgical procedure and surgical technique, there are other general risk factors for bleeding which should be considered in the assessment. For example, acquired bleeding disorders in the context of acute liver or renal failure, concurrent use of anticoagulants are known. Acute stroke patients should be discussed with neurology, and thrombocytopenic patients and patients with bleeding disorders such as hemophilia and von Willebrand disease should be discussed with hematology, and then again hypertensive patients with ICU specialists, because uncontrolled systolic hypertension greatly predisposes patients to bleeding. So to ensure appropriate and timely prevention of VTE, the risk assessment should be completed as per your local protocol. In the case of UCLH, this would be EPIC, which is electronic health record software used throughout the trust. And this should be done as soon as possible after the admission, or at least by the time of the first consultant review. If thromboprophylaxis is deemed inappropriate, this should be discussed with the patient and the reason documented on the VTE note. On your record or when clinical. So done assessment have to ensure mobility strategy risk. It may be emphasized not protect risk, not at in specific, which of time on this during. Lastly, we should be feasible to solve be avoided if pharmacological thromboprophylaxis is timed appropriately. Women on combined hormonal contraception are at an increased risk for VTE, so combined hormonal contraception should be preferably discontinued, and obviously adequate alternative contraceptive arrangements made by the surgical team 4 weeks before major active surgery, all surgery to the legs or pelvis, or surgery which involves prolonged immobilization of lower limb, and it should then be recommended at the first menses occurring at least 2 weeks after full mobilization. Alternatively, a progestogen-only contraceptive may be offered, and the estrogen-containing contraceptive restarted after mobilization. VTE thromboprophylaxis is advised when discontinuation of an estrogen-containing contraceptive is not possible, for example, after trauma, or if a patient admitted for an elective procedure is still on an estrogen-containing contraceptive, and the duration of thromboprophylaxis may need to be prolonged. So these recommendations, however, do not apply to minor surgery with short duration of anesthesia, for example, laparoscopic sterilization or tooth extraction, and these recommendations also do not apply to women using estrogen-free hormonal contraceptives. Transdermal hormonal replacement therapy has little or no impact on coagulation and is not associated with an increased risk of VTE in healthy women, so there is no need to discontinue transdermal hormonal replacement therapy prior to elective surgery when the surgery is minor, will not involve immobility, and the patient is otherwise fit and well. But it should be considered whether there are additional patient or procedure-related risk factors present, and in cases where patient is taking high-dose estrogen patches of greater or equal to approximately 100 micrograms, and these should be stopped 1 week preoperatively and then restarted 1 week postoperatively, or as soon as the patient is mobile, whichever is earlier. And then for oral hormonal replacement therapy, this should be stopped 4 weeks before elective surgery and then restarted at least 4 weeks after surgery when the patient is fully mobile. So assuming there are no contraindications for VTE thromboprophylaxis, it should be restarted within 14 hours after VTE risk assessment and continued until patient is no longer at an increased risk of VTE. Due to their potential to increase the risk of GI and other bleeding, non-steroid anti-inflammatory drugs should be avoided or used with caution in patients on low molecular weight heparins, direct oral anticoagulants, or antiplatelet agents. This guidance may change eventually. There is evidence to support both approaches. However, at UCLH, we still deem that to be the case. We may get new evidence in the next year or so. There are studies supporting both approaches, and we'll just see what the time brings. But again, I think the prudent approach, especially in patients with high risk of GI, is to obviously discontinue NSAIDs and go with alternative pain management strategies such as clonidine, ketamine, magnesium, and other analgesic drugs. So in our institution, enoxaparin is the low molecular weight heparin of choice for thromboprophylaxis in most medical and surgical patients, and the standard dosing is 40 milligrams once daily for patients weighing 50 to 100 kilograms with normal renal function. Obviously, patients who should not receive enoxaparin are those with clinically significant active bleeding, hypersensitivity to heparin, or low molecular weight heparin, and other absolute and relative contraindication listed here, which are general contraindications. So I assume that that's the same case in your hospitals as well. Patients with renal impairment, which is defined as creatinine clearance of 20 to 30 mils a minute, should all receive half the normal dose, which is 20 milligrams once daily. And patients with greater renal impairment should be discussed with hematology. The same applies to frail and patients weighing less than 50 kilograms. And for obese patients weighing 100 to 149 kilograms, normal daily dose should be increased from 40 to 40 milligrams twice daily. And for heavier patients, 150 to 200 kilograms, that should be increased to 60 milligrams twice daily. Patients heavier than 200 kilograms should again be discussed with hematology. And while on enoxaparin, patients should have baseline full blood count and urea and electrolytes done, and an additional platelet check 24 hours post last dose of any heparin. And that's obviously to monitor for heparin-induced thrombocytopenia and any changes to renal function. So recently, our local hematology team started advising us to perform anti-10A levels 2 to 3 hours post last administered dose of enoxaparin to monitor the effects of enoxaparin and potential dose adjustment in certain patient populations, such as patients with renal disease or patients who are obese, based on a couple of prominent studies that were analyzed in the stratified meta-analysis published in 2024. This meta-analysis from 2024, encompassing more than 3,600 patients, has shown that anti-10A measurements were associated with a reduced risk of VTE compared with using a fixed standard dose of low molecular weight heparin. So hopefully this will be incorporated as the gold standard in the next revision of our local VTE thromboprophylaxis guidelines to improve outcomes. And obviously, we'll have a look at what the European guidelines say about that in down the line of this presentation. So for patients who bleed while on enoxaparin, the first step is to discontinue or delay or skip next dose of enoxaparin as appropriate. And if there's a surgical cause of bleeding, take patient to theater to find the site of bleeding and apply appropriate hemostasis using ligation of the vein or artery. And in some cases, tranexamic acid. We see that in our institution that's now being used more frequently than in previous years. So hopefully that remains a good trend to be seen. And then next step is to obviously consider mechanical thromboprophylaxis where appropriate, and we're going to spend some time on that as well. Thromboprophylaxis agents increase the risk of spinal hematoma when used in the setting of neuraxial interventions, such as spinal or epidural placement. So timing must be carefully planned. These guidelines apply to thromboprophylactic doses of low molecular weight heparin only, and obviously not to patients on therapeutic doses. But for thromboprophylactic doses, we should wait at least 12 hours after last dose of prophylactic enoxaparin before insertion or removal of epidural catheter, or even longer in case of renal failure. In our institution, it may go all the way up to 18 to 24 hours, depending on hematology advice. Equally, we should wait at least 4 hours after removal or insertion of epidural catheter before giving prophylactic dose of enoxaparin. For the sake of time, we will omit special considerations for lighter patients and move on to direct oral anticoagulants or DOACs and antiplatelet agents, which are another common set of medications that we use for VTE thromboprophylaxis. So DOACs should not be used around the time of spinal intervention or with an epidural catheter in situ, and in case of inadvertent administration, advice should be sought from the coagulation registrar at our institution, and I would assume hematology would be the first call you would make in any other hospital. Equally, epidural, spinal, or regional anesthesia is considered to be contraindicated for urgent surgery or procedures in patients with insufficient time for safe withdrawal of DOAC or any other therapeutic anticoagulant. For antiplatelets, anesthetist or coagulation registrar should be consulted if the patient is taking more than 150 milligrams of aspirin once daily or aspirin at any dose with concurrent low molecular weight heparin, and or taking NSAID or any other antiplatelet agent, which is common in patients taking dual antiplatelet therapy for coronary or carotid stenting. So for majority of patients taking low molecular weight heparin, routine monitoring for heparin-induced thrombocytopenia or HIT is not required, but all patients that have received any form of heparin must have a baseline platelet count done in addition to other baseline bloods such as unis. So for those who have had any type of heparin within the previous 100 days or 3 months, an additional platelet check is required 24 hours after receiving first dose of heparin, just because there might be a slightly increased risk of HIT. HIT monitoring is therefore only required for cardiothoracic patients or those who received unfractionated heparin during the current episode where the incidence of HIT is expected to be greater than 1%. We'll now quickly cover two non-pharmacological options for VTE thromboprophylaxis, which are anti-embolism stockings or AES and intermittent pneumatic compression devices or IPCs, commonly called Flotrons here in the UK. And these mechanical options should be considered based on patient surgical procedures and should be continued until patient's level of mobility is no longer significantly reduced. Stockings are generally safe, but there are a couple of scenarios where these are contraindicated, such as acute stroke, suspected or proved peripheral arterial disease, peripheral arterial bypass grafting, peripheral neuropathy, or other causes of sensory impairment to lower extremity, any local conditions where stockings may cause damage, such as fragile skin, dermatitis, and recent skin graft. Additionally, known allergy to material, severe leg edema, and unusual leg size, shape, or major limb deformity that is preventing correct fit all preclude the use of stockings. In summary, stockings are not recommended for general medical patients, neutropenic and vascular surgery patients for reasons discussed, and while not recommended, they can be considered for general medical patients if there is a contraindication to pharmacological thromboprophylaxis. Floatrons or intermittent pneumatic compression devices can be considered alternative to stockings depending on the VTE risk of the patient balanced against the bleeding tendency. They have similar list of contraindications, but generally, floatrons provide slightly better VTE thromboprophylaxis than stockings, and if indicated, should be used for as much time as possible until patient regains full mobility. We're also going to look at the European Society of Anesthesia and Intensive Care guidelines later on their recommendations for mechanical VTE thromboprophylaxis. So if despite our diligent efforts to prevent VTE, so to ensure that there is an appropriate VTE thromboprophylaxis, if a case of DVT or PE is suspected, we should follow the hospital guideline on the suspected DVT PE and also base that on advice from a hematology or coagulation registrar. And we should consider starting treatment dose of enoxaparin or unfractionated heparin depending on your local policy, so as soon as possible, and arrange an urgent venous Doppler or ideally duplex scan for suspected DVT, or arrange an urgent CTPA or Vicky scan, whichever is more readily available in your institution, if clinically appropriate in cases of suspected pulmonary embolism. So we discussed some general principles of VTE thromboprophylaxis, and to conclude, we're going to do an extensive overview of perioperative VTE prophylaxis guidelines from European Society of Anesthesia and Intensive Care that were published in their second revision in August 2024 and are publicly available on the Society's website linked below. These guidelines are endorsed by 12 European surgical societies and are quite detailed, but we're only going to review the key takeaways as depicted in the infographics provided. There are 11 different types of surgical specialties or considerations covered, along with specific chapter on mechanical prophylaxis, and we're going to review them individually. For those of you who will take extra notes, it is also worth mentioning that there is a numbering error, and there appears to be chapter 7 missing, but chapter 8 should actually be chapter 7, and chapter 9, chapter 8, and so on. So just out of interest, I found that that's the case. But now moving on to first chapter that deals with VTE thromboprophylaxis for patients undergoing cardiovascular surgery. This is the first chapter in this 12 chapter guidelines, which basically makes recommendations for three broad categories of procedures, namely coronary artery bypass grafting surgery or CABG, vascular surgery not involving coronary arteries, and aortic aneurysm repair. So the observed incidence of VTE is around 1.3 to 1.75%, and established risk factors for VTE in this population are history of VTE, obesity, heart failure, prolonged bed rest, and mechanical ventilation. Mortality in CABG from VTE is around 6.9%, and recommendations are to start VTE prophylaxis 6 to 24 hours post-surgery, provided there is absence of significant bleeding risk. For aortic aneurysm repair, incidence of VTE is almost 6 times that of peripheral vascular surgery, with additional VTE risk factors being obesity, postoperative pneumonia, and prolonged mechanical ventilation longer than 2 days. Initiation of pharmacological VTE thromboprophylaxis within 24 hours post-procedure should be considered in patients who had open thoracoabdominal aortic aneurysm repair, abdominal aortic aneurysm repair, and thoracic endovascular aortic repair, and also in patients with increased VTE risk factors, provided there are no significant risks of bleeding. So low molecular weight heparin should be considered as first-line therapy over unfractionated heparin infusion, in view of increased risk of heparin-induced thrombocytopenia in cardiac and vascular surgery, which we've touched upon in the previous slides. So the next chapter is on perioperative VTE thromboprophylaxis for thoracic oncology surgical patients. So the authors of the guidelines have recognized that thoracic oncology surgical patients are one of the highest risk groups for postoperative VTE, and they recommend that VTE thromboprophylaxis is started preoperatively using low molecular or unfractionated heparin, which is better than no prophylaxis. But again, low molecular weight heparin is preferred over unfractionated and also preferred postoperatively. Non-direct oral anticoagulants are preferred over direct oral anticoagulants, and they also suggest combination of pharmacological and mechanical thromboprophylaxis over pharmacological prophylaxis alone, and patients should also be receiving mechanical thromboprophylaxis over no prophylaxis where feasible. So whatever you do, in very plain language, whatever you do is better than nothing. However, there are some preferences, and all this should be considered on an individual basis for that particular patient. So in terms of postoperative VTE thromboprophylaxis, lobectomy and segmentectomy patients should be further stratified in low, moderate, and high-risk groups, and the length of thromboprophylaxis should be adjusted accordingly. So low-risk patients should receive in-hospital prophylaxis only where moderate to high-risk patients who should receive extended prophylaxis for 28 to 35 days or 4 to 5 weeks. Patients undergoing pneumonectomy and extended lung resection should all receive extended thromboprophylaxis for 4 to 5 weeks and also routine screening for postoperative VTE. So basically, pneumonectomy and extended lung resections are the most thrombogenic procedures. So patients should receive both preoperative low molecular weight heparin prophylaxis and postoperative 4 to 5 weeks thromboprophylaxis. We've had a chat with our local team about this, and it would be interesting to hear your opinion, but in most cases, they deem that to be quite unrealistic, given that patient compliance drops after 2 to 3 weeks. But it's a very interesting recommendation, and I think everybody should strive for that, given that there is ample evidence to show that patients fare better after the 1 month mark if they are given routine thromboprophylaxis. So that's just a personal comment on the guideline when this was first presented at our departmental meeting. Next chapter may be of interest to many of you due to sheer volume of patients that most anesthetists face on a daily basis, and these are day case and fast track surgeries. Also, those are all surgeries that apply the principles of enhanced recovery after surgeries or ERAS protocols. In the guidelines, they firstly suggest risk stratification, which we've already mentioned, similarly to the approach that I proposed at the beginning. So based on patient and procedure-related risk factors for VTE, and obviously group them in either minor or major risk factors. They also introduced the Caprini VTE risk calculator, which has been validated for surgical population and is also freely available online. If the patient has one or more factors from major risk category, they should strongly be considered for preoperative VTE thromboprophylaxis. So obviously the first recommendation is that all patients should be assessed preoperatively for VTE risk, and then the guidelines offer an easy to understand decision model to guide VTE thromboprophylaxis. So all patients undergoing low risk surgery should simply receive general VTE risk reduction measures such as mobilization and optimal hydration, whereas patients for high risk surgery defined in this infographic under major procedure related risk factors should additionally be also considered for mechanical thromboprophylaxis. Post-surgery, all patients should continue general VTE thromboprophylaxis measures, and those with additional patient-related factors should additionally be started on low molecular weight heparin, VTE thromboprophylaxis for a minimum of 7 days or 4 weeks for those who underwent high-risk surgery. Alternatively, mechanical thromboprophylaxis or intermittent pneumatic compression or floatrons should be considered in patients with an increased risk of bleeding. Next chapter in these guidelines is VTE thromboprophylaxis in critical care patients, which present a special group in terms of risk factors for VTE. So pre-admission, these patients may have had recent high-risk surgery, sepsis, trauma, cancer, stroke, advanced stage, or other underlying disorders predisposing them to increased risk for VTE, such as previous DVT/PE, and also cardiac or respiratory failure. So on admission, these patients are mostly immobile, sedated, or receiving muscle relaxants and vasoactive drugs, mechanically ventilated, and suffering from cardiac or respiratory failure, renal insufficiency or end-stage renal failure, or acute kidney injury requiring hemodialysis. They can also be septic or have central venous line inserted or have had invasive procedures done, which are all specific risk factors for VTE in this very brittle ICU population. So the incidence of VTE in ICU patients is high and varies from 10 to 90%. So very broad range, depending on both patient and surgical risk factors. Despite the use of guideline recommended protocols, ICU-specific complexities such as organ failure, immobilization, and therapeutic limitations warrant a more tailored approach. So pharmacological prophylaxis is recommended as the first-line strategy in ICU patients without contraindications, and low molecular weight heparins, again, are favored over unfractionated heparin due to better bioavailability and fewer dosing complications, although unfractionated heparin or dartaparn is preferred in cases of severe renal dysfunction. So in patients with heparin-induced thrombocytopenia, argatroban is recommended as first-line anticoagulant, and for patients at high risk of bleeding, mechanical prophylaxis, particularly intermittent pneumatic compression, is recommended over no prophylaxis. IPC is also preferred over graduated compression stockings due to superior efficacy in reducing VTE rates. Evidence does not support routine use of graduated compression stockings in critically ill medical patients, and a combination of low molecular weight heparin and IPC may be beneficial for selected high-risk surgical ICU patients, although data remains inconclusive for broad application. Intermediate dosing of low molecular weight heparins, such as enoxaparin 40 to 60 milligrams daily, may strike a better balance between efficacy and safety compared to standard low-dose regimens, especially in obese or trauma patients. Interestingly, routine monitoring of anti-10A levels is not advised except in specific populations, such as those with renal impairment or morbid obesity, which is in line with what we've discussed earlier with the new local guidelines that we're developing. So in these groups, which are patients with renal impairment and morbid obesity, anti-10A adjusted dosing protocols may help optimize safety and effectiveness. And in summary, the guidelines basically advocate for individualized, evidence-informed VTE prevention strategies, balancing the risk of thrombosis against the risk of bleeding, while emphasizing a pragmatic and patient-centered approach to prophylaxis in intensive care settings. Next chapter is mechanical VTE thromboprophylaxis. So these guidelines underscore the nuanced role of mechanical thromboprophylaxis, which is primarily graduated compression stockings and intermittent pneumatic compression, or IPC. Mechanical methods are valuable adjuncts or alternatives to pharmacological agents, particularly in patients at high risk of bleeding, as they do not interfere with the hemostatic system per se. Evidence for graduated compression stockings is mixed. While older trials suggest benefit in surgical patients, more recent high-quality data indicate limited efficacy, especially in low-risk or immobilized medical patients, and there is a potential for skin complications as well. In contrast, IPC has shown more consistent benefits, particularly in high-risk surgical cohorts, also improving venous return and reducing DVT risk, even when compared with placebo or graduated compression stockings. However, there was quite a heterogeneity among studies, variations in procedure type, patient risk profiles, and reliance on systematic screening for asymptomatic VTE, which then limits the generalizability of these findings. So combined therapy which would be ideally IPC plus low molecular weight heparin or unfractionated heparin, and PE reduction in high-risk patients compared to either modality alone. So we achieve synergism by utilizing and pharmacological prophylaxis, obviously in patients who are eligible for this type of therapy. Although, again, both mechanical and pharmacological prophylaxis may increase risk of bleeding in patient populations who already have increased risk of bleeding. So basically, this infographic synthesizes 8 great recommendations. One is to implement institution-wide protocols integrating early ambulation, pharmacological, and mechanical prophylaxis, which has grade 1B, which is a high grade quality of evidence. We need to assess VTE and bleeding risk preoperatively for all patients and in low-risk patients. So patients, for example, for day surgery, we should favor general measures over prophylaxis alone. So optimal mobilization and hydration. And then for immobilized low-risk patients, we should use pharmacological prophylaxis. IPC is optional, and for high thrombosis risk plus high bleeding risk, IPC is recommended. And for high thrombosis and low bleeding risk, pharmacological prophylaxis and or IPC or GCS can also be added as per clinician discretion. For very high-risk patients, the guidelines suggest both mechanical and pharmacological prophylaxis. And in conclusion, basically, mechanical prophylaxis, especially IPC, plays a supportive but context-specific role in VTE prevention. Again, clinical decisions must balance thrombosis risk, bleeding potential, and procedural factors, aiming for individualized and evidence-informed approach. So the next chapter is neurosurgery, and the 2024 European guidelines provide updated evidence-informed recommendations for VTE prophylaxis in neurosurgical patients. Given the high variability in reported VTE incidence across spinal and intracranial procedures, these guidelines emphasize individualized thromboprophylaxis based on patient-specific and procedural risk factors. Spine surgery carries a thrombotic risk influenced by factors such as surgical invasiveness, spinal segment involved, and oncologic indications. And reported DVT rates range from 0 to 36%. And basically, the guidelines recommend early mobilization, preoperative initiation of intermittent pneumatic compression, and postoperative pharmacological prophylaxis, preferably with low molecular weight heparin initiated within 24 to 48 hours post-surgery once hemostasis is adequate. Intracranial surgery presents unique challenge due to the risk of postoperative intracranial hemorrhage and VTE incidence ranging from 1 to 6% is significantly higher in patients with malignancy, motor deficits, obesity, or prolonged surgery. It's interesting that in this patient population, intermittent pneumatic compression may reduce DVT risk by up to 60%. And while low molecular weight and unfractionated heparins both reduce thrombotic risk, again, low molecular weight is preferred due to lower bleeding risk. Anti-10A monitoring is recommended where anticoagulation is used. And in patients with non-traumatic intracerebral hemorrhage, mechanical prophylaxis can be initiated early. Pharmacological prophylaxis may safely begin 2 to 4 days after bleeding if hemostasis is stable, aligning with findings from the famous CLEAR-3 trial that delayed anticoagulation increases VTE risk. So those are the main highlights from the neurosurgical chapter from the European Society of Anesthesia and Intensive Care guidelines. Moving on to next set of recommendations, which apply to plastic surgery. So plastic surgery patients, particularly those undergoing abdominal contouring and reconstructive procedures, are at a heightened risk of venous thromboembolism, especially deep venous thrombosis and pulmonary embolism. And according to the 2024 European guidelines, The 2005 Caprini risk assessment model remains the best available tool for stratifying VTE risk in this population. Procedures such as abdominoplasty, particularly when combined with liposuction or hernia repair and microsurgical breast reconstruction with long operative times and hospital stays, carry significant thromboembolic risk. And for these patients, the guidelines recommend low molecular weight heparin administered once daily in the postoperative period, and in morbidly obese patients defined as BMI over 40, a higher prophylactic dose of low molecular weight every 12 hours should be considered to maintain effective anticoagulation. The recommended duration of chemoprophylaxis ranges from 7 to 30 days, depending on the patient's Caprini score. And importantly, while mechanical prophylaxis such as intermittent pneumatic compression may be beneficial, its efficacy in plastic surgery remains under-evaluated and needs further study. Notably, the guidelines state that there is insufficient evidence to support the use of direct oral anticoagulants or DOACs in plastic surgery because these agents may increase bleeding risk in surgeries involving extensive tissue manipulation. And again, these should not replace low molecular weight heparins until more plastic surgery specific data are available. So basically, in summary, VTE prevention in plastic surgery must again be personalized, risk adapted, and based on established models such as Caprini risk assessment model, and low molecular weight heparins remain the standard of care with dose and duration adjusted to risk, especially in obese patients or complex procedures. We are now going to quickly look at the VTE thromboprophylaxis recommendations for surgery during pregnancy and the immediate postpartum period. So pregnancy and postpartum period present a uniquely elevated risk for venous thromboembolism or VTE, especially around the time of surgery. So the latest 2024 guidelines emphasize personalized VTE risk assessment as a critical safety tool to reduce maternal mortality. And this risk should be evaluated before any surgical intervention and updated postpartum, regardless of delivery mode. For cesarean section, the recommendations remain unchanged. So thromboprophylaxis is advised for all patients, except those undergoing elective procedures with clearly low risk, though no universal definition exists for this low risk category. For high-risk women, prophylaxis should continue for at least 6 weeks, and for others, a minimum of 7 days is recommended. In non-obstetric surgeries performed during pregnancy or early postpartum period, no new data have emerged, and the previous 2018 guidance still applies. So thromboprophylaxis should be administered whenever surgery results in immobility due to the combined risk of pregnancy and surgery. Recent evidence supports weight-based, low molecular weight heparin dosing, especially for women with BMI over 40, who benefit more from weight-adjusted regimens compared to fixed dosing. For patients with a history of VTE, both low-dose and intermediate-dose low molecular weight heparins are considered equally effective, which is interesting. And for mechanical thromboprophylaxis, while compression stockings do not have a proven VTE prevention benefits in surgical pregnancy, they are clinically supported for reducing hypertension, improving hemodynamics, and enhancing comfort during and after surgery. So this basically sums up this section of the guidelines. And the next set of recommendations is for the surgery of in the obese patient. So the 2024 guidelines underscore that obese patients, particularly those undergoing bariatric surgery, are at elevated risk for venous thromboembolism, with symptomatic VTE incidence ranging from 0.3 to 3%. Risk increases with patient-related factors such as high BMI, male sex, history of VTE, obstructive sleep apnea, and prolonged hospital stay. Procedure-specific risks include open surgery, long operative times, and complications like anastomotic leaks. For bariatric surgery, the guidelines recommend pharmacological thromboprophylaxis with low molecular weight heparins, unfractionated heparin, or fondaparinux over no prophylaxis in high-risk patients. Low molecular weight heparin obviously is preferred over unfractionated heparin or direct oral anticoagulants due to limited evidence and potential malabsorption with direct oral anticoagulants because pharmacokinetics and pharmacodynamics are a bit changed in the obese patient. Higher than standard dosing is suggested for patients with BMI above 40 or weight above 150 kilograms, though routine monitoring of anti-10A levels is not recommended in this patient population. The use of combined prophylaxis, which is mechanical plus pharmacological, is strongly advised for patients with high thrombotic risk, and extended prophylaxis for at least 10 days postoperatively is recommended over inpatient-only regimens, given that up to 80% of VTEs occurred after discharge. In non-bariatric surgery, evidence is weaker and mixed. Nonetheless, higher low molecular weight heparin dosing may be considered for morbidly obese patients at high VTE risk and low bleeding risk, though definite recommendations remain cautious due to conflicting data on efficacy and bleeding complications. So in conclusions, again, the guidelines advocate a tailored VTE prevention strategy in obese patients, again, balancing thrombotic and bleeding risks, which includes dose-adjusted pharmacological prophylaxis, mechanical methods when needed, and extended post-discharge prophylaxis in high-risk individuals, which again, all that is because up to 80% of VTEs occur after discharge in this patient population. Next, we're going to have a look at the recommendations for trauma patients. This patient population presents a unique and high-risk population for venous thromboembolism due to rapidly evolving coagulation states, frequent immobilization, and complex clinical scenarios. So the 2024 guidelines recommend a stratified and evidence-informed approach to thromboprophylaxis in trauma with an emphasis on early pharmacological intervention and individualized protocols. So for severe trauma without neurotrauma, the guidelines strongly supports initiating pharmacological prophylaxis within 24 hours because delays are associated with significantly increased VTE rates. In non-operative management of solid organ injuries, early prophylaxis, so within 24 hours, is also preferred, though in high bleeding risk cases, such as severe splenic or liver injury, a delay of up to 72 hours or 3 days may be appropriate. For traumatic brain injury, early pharmacological prophylaxis within 48 hours may be initiated if no hemorrhagic progression is seen on follow-up CT. In patients requiring urgent neurosurgery or at high risk of bleeding, prophylaxis should be delayed and assessed case by case. When anticoagulants are contraindicated, IPC is recommended as first line with low molecular weight heparin added once the bleeding risk declines. Spinal cord injury patients should begin pharmacological prophylaxis within 48 hours, and therapy should continue for 3 to 6 months, particularly when neurological deficits are present. Combining low molecular weight heparins with IPC is recommended for those with motor impairments. Regarding drug selection, again, low molecular weight heparin is preferred over unfractionated heparin due to better VTE prevention and lower complication rates. Direct oral anticoagulants may be an alternative in select polytrauma cases, although evidence remains limited. Finally, the guidelines strongly advise against the routine use of inferior vena cava filters for primary prevention in trauma due to lack of proven efficacy and potential harm. So again, the guidelines, the updated recommendations underscore the importance of early, risk-tailored, and multimodal prophylaxis to effectively prevent VTE in trauma patients while minimizing bleeding risk. Last but not least, let's quickly go through the recommendations for urology patients. So the 2024 guidelines are built on great methodology and categorize patients into 3 distinct groups. So first, for patients undergoing low-risk day surgery procedures like circumcision, vasectomy, hydrocolectomy, and ureteroscopy, The guideline strongly recommends against pharmacological and mechanical thromboprophylaxis. The risk of symptomatic VTE is comparable to the general population, and intervention may only increase bleeding risk and healthcare burden without meaningful benefit. Second, for patients undergoing high-risk procedures, such as open radical prostatectomy with extended lymphadenectomy or open radical cystectomy, the panel strongly recommends pharmacological prophylaxis and suggests mechanical methods until ambulation. These procedures carry a consistently high VTE risk, which outweighs the bleeding risk across patient risk strata. Third, for most other urological procedures, including robotic-assisted prostatectomy, the recommendation is nuanced and tailored to the procedure type. So lymphadenectomy, for example, would require low molecular weight prophylaxis post-surgery, and other patient-specific factors like age, BMI, and VTE history also play a role in decision-making. For example, in robotic prostatectomy with extended lymphadenectomy, prophylaxis is strongly recommended only for high-risk patients, while it is discouraged in low-risk individuals. So basically, key principles include start thromboprophylaxis on post-operative day 1 to reduce bleeding risk, as most bleeds occur perioperatively, while VTE risk rises post-operatively. We should continue prophylaxis for 2 to 4 weeks, as nearly half of all VTEs occur within the first week post-surgery. And we should use low molecular weight heparins as the primary agent, with direct oral anticoagulants as a reasonable alternative in suitable patients, though with caution in those with delayed gastric motility or ileus, because lower absorption basically entails a whole host of other different pharmacokinetic and pharmacodynamic problems in these patients. So this basically summarizes the urology section. And lastly, we're going to quickly have a look at the guidelines for non-ambulatory orthopedic surgical patients. So non-ambulatory orthopedic surgery remains one of the highest risk settings for venous thromboembolism. And the panel defines non-ambulatory surgery as procedures requiring at least one overnight hospital stay. Most commonly, that includes total hip or knee arthroplasty, hip fracture repair, and other major lower limb surgeries. While VTE risk is clearly elevated in these settings, the bleeding risks of pharmacological prophylaxis, especially in the presence of drains or coagulopathy, must be carefully weighed. So a central recommendation is to prioritize fast-track pathways, including early ambulation and joint mobilization, which significantly reduce VTE risk and have no contraindications. For low-risk surgeries such as minor arthroscopies or upper limb procedures, no pharmacological prophylaxis is suggested in patients without personal VTE risk. However, in patients with elevated personal risk and low bleeding risk, low molecular weight heparins or direct oral anticoagulants may be appropriate. Where bleeding risk is high, mechanical prophylaxis is preferred. And in high-risk surgeries like hip or knee replacements, pharmacological prophylaxis is recommended, again, using low molecular weight heparins or DOACs, unless bleeding risk is prohibitive. When bleeding risk is significant, mechanical methods like IPC or graduated compression stockings should be employed. Notably, total hip arthroplasty, total knee arthroplasty, and hip fractures are strongly recommended for pharmacological prophylaxis. In fast-track variants of these surgeries, aspirin has emerged as a validated alternative, especially in low-risk patients. So basically, in summary, this chapter again reinforces the value of procedure and patient-specific assessment, combining pharmacological and mechanical methods as needed with strong support for enhanced recovery strategies. And this all offers optimal VTE prevention while minimizing complications and supporting patient-centered recovery. So this brings us to the end of my presentation. Hopefully this presentation was useful for your clinical practice. So as per slide, keep calm and stop the clot. So please let me know if you have any questions, and thank you for your attention.
Thank you so much, Dr. for such an amazing presentation. It has been very insightful. The topic and information that you have presented is very relevant to the kind of population of patients that we anesthetize. I want to open the floor for any questions, any clarifications.
Good evening, everyone.
Good evening.
Good evening.
Two issues. I found it interesting about the contraindication of the TED stockings for acute stroke. I would wish to know whether we are talking about hemorrhagic stroke or infarctive stroke or both, and why that would be the case. And then what you have presented is quite a mouthful. Thank you for the deep work. I'm wondering whether there is a simplified version of remembering all this. It's quite a bit to remember on a day-to-day basis. Thank you.
Perfect. Thank you for the comment and for the question. Going to the question first, I think the stockings are contraindicated for patients with stroke for two reasons. One is that they do not offer any notable efficacy in terms of VTE prevention. So studies have shown that actually stockings, if they are not particularly tailored for that specific patient, for their leg anatomy, they do not provide any reduction in VTE risk. And then the reason why they're contraindicated is they don't offer any reduction in VTE risk. However, they offer a host full of other potential disadvantages, such as skin infection, ulcers, and may actually, from that point of view, be not so beneficial as we originally thought. So those were the main arguments in the guidelines why they are contraindicated. And the second is patients with a stroke normally can't tell you if they feel like the stockings do not fit them or if there's any ulcer. So that again brings us back to the reasons why they avoided this in the guidelines. Intuitively, it would seem that they are actually providing some benefit, but it turns out that if you want to offer some benefit in terms of VT risk reduction, proper hydration, and intermittent pneumatic compression, which again is a device that the department has to have and the nursing staff needs to know how to use it, actually offers the only reasonable VT risk reduction. And then again, that leads into a host full of other issues. If you're optimizing hydration, how do you measure that? Do you measure that clinically? Do you do any hemodynamic monitoring? And then we're again in the gray zone where we don't have studies to support any of the interventions, and we're back to square one. So if you want to offer some VT risk reduction to your patient, what we do at UCLH with these patients is we ensure that they are clinically hydrated. We measure that based on lactate levels, urine output, base excess, and also clinically, we would measure the skin elasticity clinically. And also what we would do is we would offer patients with personal factors predisposing them to higher VTE risk. We would vet them, and they would some of the patients would receive intermittent pneumatic compression. It's also important to know that in patients with stroke, especially if it's not clear why stroke occurred, this will tie in with the one of the cases that I had. It was actually the cases that led me to become really interested in this topic, was that in patients who have had a stroke and they don't have any risk factors that would explain why that is, any family history, or they're quite young, what you may wish to consider is doing a transthoracic echocardiography to check if there is any communication between right and left heart. So in one of my clinical cases, we had a patient who had paradoxical embolus. So he had a DVT, which would have been a PE, and it ended up being a PE and a stroke. Okay, so that's a very specific situation, but in some patients, it may not manifest as PE, it may manifest as a stroke only. So in these patients, you may want to take a different approach by not only giving them IPC, but also giving them a vena cava filter, which in most patients is contraindicated, but in select cases like this would be indicated. So hopefully I've answered your question to some extent. I know I've opened a lot of other sub questions, but then again, it's an ongoing debate why that is. But then again, the main highlight is graduated compression stockings, especially the ones that are basically just sized for all patients the same, so there is no difference between, so they're basically in small, medium, large, and extra large sizes. They don't provide any significant benefit, and if they don't provide benefit while adding some extra risk in terms of skin infection or in terms of ulcers or even allergies to materials, there is no use in using them. And there was actually a study saying that not only are they not doing what they're supposed to do, they're actually costing healthcare systems a lot more than we thought. We know that these are not just regular stockings with regular prices, but they're deemed as medical devices, which just increases the risk of well, over budgeting for interventions that don't bring any benefit. And lastly, to answer the second question, I know there was a lot of information. The slides are very busy. I wanted to give you a lot in this hour, and I know that each and every single one of you probably took what you normally do on your daily basis. So you probably chimed in more on the sections that were of your professional interest, but I'm happy to share the actual link to the guidelines where they've made a summary of the infographics in a slightly smaller version of the PDF. So you can have a look at all these different recommendations in 5 to 10 page PDF, which can be useful for your clinical practice as well. But then it also depends on your local institutional guidelines and how your service in your hospital is organized. I always feel like if you have the liberty of calling hematology in your hospital to give you a tailored advice, it turns out to be a much more informed and multidisciplinary decision rather than just deciding for a very vanilla approach of just prescribing patient whatever you deem to be appropriate dose for them. So in our hospital, we really want to do a personalized approach for patients and for VTE risk reduction, just because it's looking at the stats and doing an internal audit, we see that even subclinical PEs, which manifest most commonly as shortness of breath or just elevated D-dimer or even troponin, they would normally be down the line prognostically significantly worse for the patient than if we were not monitoring them and offering them VTE risk reduction strategies and personalized approaches to their VTE prevention. So we're quite hopefully strong on that, and we want to convey the message that obviously whatever you do is better than nothing, but then there's a whole host of interventions for different patient populations that, in view of the latest guidelines, I think everybody should take a bit of time to study and obviously formulate either your personal approach to that, or if you're in the capacity or if you have the resources to advocate on a departmental level for these guidelines to be developed and used to offer benefit to patients, even when you're not on call, even when you're not at that specific case. So yeah, hopefully that was a short / medium long answer to your questions. And if you have any follow-up questions, happy to discuss them.
Any more questions? Any more remarks? There's a question on the chat box from Dr. Janak. For patients on oral HRT, often there are patients who had bilateral ovaries removed and are on oral hormonal replacement therapy, undergoing bariatric surgery. In these cases, you cannot stop HRT 4 weeks prior to surgery. What would your advice be?
I think it's not the question of stopping the oral HRTs. I think it's more the question of whether you advise these patients to start preoperatively on 1 week course of low molecular weight heparins, provided that they're immobile. So I think that this should always be a multidisciplinary decision. And I know that there are teams that prioritize hormonal replacement therapy. So in this case, patients should continue with normal oral hormonal replacement therapy. And basically, it should be, again, a very tailored approach. So if you have a patient, female patient undergoing bariatric surgery, those are two different risk factors. So one is the oral HRT, knowing obviously what is it an estrogen, is it a progesterone? Estrogen obviously increases the risk, and then all the other risk factors associated with the bariatric surgery, what type of surgery, what's the immobility. So I would suggest that always have multidisciplinary meetings for these types of decisions. There's obviously not a one size fits all. And with bilateral oophorectomy, I would assume that patients, especially if these are patients who had ovaries removed due to cancer and have not had menopause yet, they obviously would benefit from hormonal replacement therapy more than the patients who have that done during menopause or after menopause. So I've had a couple of these patients, and generally for a couple of patients, it was decided that if, for example, hormonal replacement therapy was indicated for a patient who had very severe night sweats and also had developed sarcopenia, so she was at very high risk for various complications of withdrawing oral hormonal replacement therapy. So the decision was to start her on low dose aspirin a week prior to surgery, which in her case would have been, I think, 100 milligrams. And for one patient, it was decided to start her on, well, what would be deemed as normal dose. But in her case, that was just basically very gentle, in brackets, low molecular weight heparin prophylactic dose of dalteparin 5000 or enoxaparin 30, I believe it was. So again, it needs to be individualized. So always do your VTE risk assessment, and whenever you're in doubt, basically consult either the parent team. So we tend to have very good communication between teams. We communicate frequently with various patients who are not clear cut, and then we would come to a personalized decision whether oral hormonal replacement therapy needs to be withheld, for how long, is there any alternative that we can suggest, and then obviously VTE risk reduction is the next, or in parallel to that, that's a very important consideration to have with this patient population. Again, ovariectomies are always a bit contentious, just because we need to know the reason why that was so. Was it prophylactic? Was it a cancer surgery? I had a couple of patients who had BRCA mutation, so that those patients just wanted prophylactic ovaries removal, while in 95% of the cases that I saw in my clinical practice, those were cancer patients, which again, cancer by itself is a high risk condition for thrombosis. So it was a very easy decision to start patients on low molecular weight heparin even before surgery. So again, it all depends on the context. It depends on what the expectation for that patient is, how well they'll fare after surgery, all various different factors, which my clinical experience, and I think that's something that the guidelines are trying to develop, is always have at least 2 or 3 people involved in decision making, or 2 different specialities discussing the same patient. You get different perspective and a more holistic view of the patient trajectory and recovery, because I guess our ultimate aim is to allow patients to return to their baseline functioning as soon as possible. And just taking these isolated decisions in relatively isolated contexts sometimes may not lead to that final outcome, which is to get the patients to their baseline, and especially if they're active, to go back to their daily activities, go back to their functioning. So I know this might sound like a bit of a a very stretched debate, but I think the bottom line is discuss it with the parent team, present your case, and then they'll tell you what their reasoning is, and then you can make a very informed decision for these patients. And again, if I had more information, I would probably be able to give you a better answer. But from what I've been told, this is all I have to work with. So hopefully that gave you some food for thought, and that yeah, you got partial answer to your question.
Okay, thank you for that comment. Are there any more questions, any more remarks? I think I'd like to give a vote of thanks. Thank you for honoring our invite. Like I said earlier, you've given us quite a bit of information, which is very relevant to all of our practices. And it is our prayer that you come again for another invite. And I'd also like to thank the KSA as well for arranging all of this. Without any further questions or remarks, I'd like to call the meeting to an end.
Thank you, Leslie. Thank you everyone for being with us today, and hopefully you found it useful. I'll make sure to follow up with a PDF of the recommendations that were presented in the slides, and hopefully that will improve your clinical practice. So thank you very much. Thank you to the hosts, and I wish you a lovely evening and great week.
Thank you.